Today we are going to talk about community bacterial meningitis. Thanks for attending. As you know, acute bacterial meningitis is a disease with rapid onset, outbreak, and epidemic potential. It's associated with high rates of mortality and morbidity. The vaccination have made the etiologies different in the last 30 years. Predominantly, it is caused by three pathogens, namely Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza type B. It varies depending upon the age. In neonates, in the first month, it's predominantly group B Streptococcus, followed by E. coli, then Staph and Neisseria and Strep pneumo. The number of meningitis patients decreases as the age advances, but the spectrum of the percentage of these bacteria remains same in the first 3 months. In children, again, Neisseria, Strep pneumo predominates. And of course, we still tend to see E. coli and Staph aureus. Adults, again, Haemophilus influenza, Neisseria, and Strep pneumo predominates. Prior to the conjugate vaccine, H flu used to cause lots of meningitis. Now, Strep pneumo predominates, followed by Neisseria. In patients above 50, Listeria monocytogenes becomes another pathogen to be considered. In immunocompromised host, along with Strep pneumo, Neisseria, you will see Listeria, Staph, Salmonella, and other gram-negative bacilli. In well-resourced countries, acute bacterial meningitis incidence has fallen to below 0.5 to 1.5 per 100,000 population. In sub-Saharan region, incidence reaches 1,000 per 100,000. That means there is a 1,000 times higher in sub-Saharan area than other parts of the world. Beyond meningitis belt, and the incidence in Africa approaches 2.5 to 25. That means still the incidence is 20 times higher than global average. The global meningitis epidemiology is highly dynamic. It's based on widespread use of conjugate vaccines. Strep pneumo is the commonest cause of acute bacterial meningitis worldwide. The incidence has dramatically decreased, but still, this is the number one cause. Neisseria, conjugate meningococcal vaccine is highly effective in preventing meningococcemia and meningococcal meningitis. Serogroup C incidence declined dramatically following Men-C vaccination in high-income countries. The conjugate meningococcal vaccines are highly effective in preventing disease caused by specific meningococcal serogroups. H flu was a leading cause of meningitis in children worldwide. In addition, it was causing pneumonia, epiglottitis, and otitis media. The polysaccharide vaccine was first introduced in 85, followed by conjugate vaccine in 89. It had a significant decrease in infection since the introduction of this vaccine. Substantial disease burden, including meningitis, persists in countries India, Nigeria, Pakistan, and Democratic Republic of Congo. So the incidence is overall decreased, but there are pockets where the meningitis caused by H flu type B still persists. So how does the bacteria infect leptomeninges? The bacteria can reach the leptomeninges through the bony defects, such as those caused by mastocytitis or via bloodstream, most of the time via bloodstream. Strep pneumo, Neisseria, and group E streptococcus initially colonize epithelial surface of the respiratory tract in case of strep pneumo and Neisseria, and group B strep colonize gastrointestinal and lower genital tract. Sustained bacteremia is important for the development of bacterial meningitis. It occurs in four different ways, either through paracellular or intracellular. First, it passes through the endothelium of respiratory, GI, or genitourinary tract, then gets into the bloodstream. Then from then on, it can directly infect the astrocytes or neuronal cells, or it can activate the immune cells, thus is carried into the subarachnoid space by the immune cells. The other way of entering into the subarachnoid space is it infects neutrophils. The neutrophils immigrated into the subarachnoid space, then it gets burst into the bacteria released into the subarachnoid space like Trojan horse. And other mechanism is blood-brain barrier breakdown and leakage of the cellular material and the bacteria into the subarachnoid space. So whatever the mechanism, the early recognition of patients with bacterial meningitis is needed because of its consequences, both mortality and morbidity. Children and adults with bacterial meningitis present with headache, neck stiffness, and fever. The classic triad often talk about is neck stiffness, fever, and altered mental status. It's present only in 40 to 50% of the patients. If you depend upon this triad, that means you will miss in 50 to 60% of the patients. In neonates, it can present with some non-specific signs and symptoms like poor feeding, irritability, hypotonia, respiratory distress. Fever and seizures are the most common presenting features. So high index of suspicion is very important in neonates. So most of the guidelines do recommend routine spinal tap in those patients to rule out meningitis. Adults, the common symptoms are headache, fever, meningismus, and altered sensorium present in more than 75% of those patients. Sometimes it can present as vomiting, seizures, and focal neurologic findings. Most of the patients present with one of these four symptoms, recent onset of headache, fever, neck stiffness, and altered mental status. It is in adults. At least two of these four features present in 95% of the patients. Don't rely on that all the triad needs to be there because it's present only in 40 to 50% of the patients. Sometimes these patients have extrameningeal foci of infections like otitis media, sinusitis, pneumonia, and endocarditis. It present in 43% of the patients, meaning when the patient present with meningitis, one should look for ear infection, sinus infection, pneumonia, and endocarditis. It varies with the pathogen. In pneumococcal meningitis, 51% of them will have extrameningeal foci of infection. In meningococcal meningitis, 6%. Listeria meningitis, 11%. In adults with bacterial meningitis, one-third of them will have history of immunocompromise. Rashes in meningitis, oftentimes associated with meningococcal meningitis. It is present in 63 to 80%. The specificity when you have meningitis with rashes, the likelihood of being meningococcal meningitis is 83 to 92%. But one should remember the rash is also present in strep pneumococcal meningitis and also SUS infection. The diagnostic accuracy of meningeal signs. We used to rely on meningeal signs to make the diagnosis. The neck stiffness present only in 30% of the patients, that is inability to flex the neck. The other signs like Kernick's and Brussel's kind have poor sensitivity, only 5%. The lab diagnosis occurs in one-third of the patients because of the lack of classic triad. It's so common in older patients and those with concomitant pneumonia. It's very important. If the patient presents with pneumonia, you should look for other sites of infections, including meningitis, because delay in diagnosis associated with increased mortality 18 to 36%. And of course, it increases the morbidity too. When you do a spinal pack, when you do a spinal tap, one should know about the contraindications. When there is a brain shift due to mass lesion, one should avoid doing spinal tap in those patients. Other contraindications are coagulopathy of any reason, anticoagulant use, severe thrombocytopenia, or local skin infection at the site of puncture. When to do imaging, meaning CT head before spinal tap. When there is a new onset of seizures, focal neurologic deficit, immunocompromised state, and moderate to severe impairment of consciousness, in those conditions, you have to do a CT scan before spinal tap. But three important points to remember: start antimicrobial treatment, and adjunctive dexamethasone needs to be given before getting CT scan. So antibiotic and dexamethasone in high income countries mandatory even before doing spinal tap or CT scan when there is a contraindication to do so. Okay, when you do a spinal tap, how do you differentiate bacterial meningitis from other meningitis? First, let's look at what is normal. The CSF-CRP, C-reactive protein, is less than 10. Blood leukocyte count 4 to 10. Opening pressure 6 to 20. White cell count less than 5 cells. Protein less than zero point 0.6 gram per liter. And CSF blood glucose ratio is more than 0.6. In patients with bacterial meningitis, the CRP goes up 40 to 400. Blood leukocyte, usually hyperleukocytosis. Opening pressure is high, 20 to 50. And CSF white cell count is more than 1,000 cells. And CSF protein level high. And CSF blood glucose ratio less than 0.4. In viral meningitis patient, C-reactive protein is more or less normal, less than 10. Leukocyte count, blood leukocyte count is more or less normal. The opening pressure would be higher than normal, but it is not as high as bacterial meningitis. It's only 6 to 30. White cell, there will be CSF leukocytosis, but it is often 10 to 1,000. Protein level is not high, and CSF blood glucose ratio is more than 0.6, just like normal. In tuberculous meningitis, C-reactive protein is elevated. Blood leukocyte count is elevated. Opening pressure is high, but not to the extent bacterial meningitis 15 to 40. There is a leukocytosis in CSF, but predominantly lymphocyte. In bacterial, predominantly polymorphonuclear. There is an increase in protein content, and CSF blood glucose ratio is less than 0.40, similar to normal or viral meningitis. Similar to bacterial meningitis. Oftentimes, procalcitonin gates in making the diagnosis. Sensitivity of procal is 95%, specificity is 97%. Sometimes procalcitonin is not available, so CRP can be used. The PCR test is used to make the diagnosis of viral and bacterial etiologies. Number one, it is available in a package. In the United States, the multiplex PCR is available. It's a meningitis panel. It detects viruses and all the bacteria, meaning the most common bacteria that can cause meningitis. And the result can be available in 30 minutes to few hours. So how do you approach Diagnosis and treatment in acute bacterial meningitis. When you suspect, use droplet precautions, address the airway and circulation, draw bloods, meaning draw labs, and including blood cultures. If there is an indication for CT head prior to LP, go ahead and start DEXA and antibiotics. Then obtain CT head. It's very important. When there is a contraindication, when there is an indication, do the medication, then get the CT scan. And if there is a contraindication to spinal tap, again, DAX and antibiotics. Dexamethasone is indicated in high income countries, not indicated in low income countries. If there are no contraindications to CT scan, no contraindication to spinal tap, perform spinal tap and give DEXA and antibiotics. The dose of dexamethasone in adults, this is an adult algorithm, 10 milligram IV every 6 hours. How do you treat? Treat the bacterial meningitis, give antibiotic immediately, definitely within 1 hour of presentation. Most of the time, the risk factors for delaying the treatment, getting imaging done, and absence of typical clinical features like neck stiffness and fever. So in the clinical suspicion alone, you can give antibiotic. So what are the choice of empiric antimicrobial therapy in acute bacterial meningitis? All the guidelines strongly emphasize the antibiotics needs to be given immediately. It should not exceed 1 hour of presentation. Whenever lumbar puncture is delayed due to any reason, empiric treatment must be started immediately on clinical suspicion alone. Delay in administering antimicrobial therapy more than 6 hours increases mortality from 6 to 45% of them. That means half of them will die. Even though survivors will have increased neurologic sequelae 10 to 70%. In countries with prevalence of ceftriaxone resistant is more than 1%, that is almost all of the globe, the vancomycin should be empirically added along with ceftriaxone. Okay, we'll go age specific. In neonates, meaning less than 1 month old, suspected pathogens are strep A galactiae, which is GBS, E. coli, and Listeria. So antibiotic therapy in neonates, ampicillin plus cefotaxime or gentamicin. What to be noted is ceftriaxone is not used in neonates, so ampicillin along with cefotaxime or gentamicin. The adult dose for VANC is 15 to 20 milligram IV every 8 to 12 hours. When you're using a dosing in neonate, there is a separate dosing for the first 7 days and separate dosing for 7 to 28 days. When the patient is 1 to 23 months, suspected pathogen still strep A galactiae, which is GBS, E. coli, strep pneumo, and Neisseria. Antibiotic therapy in this age group is vancomycin plus cefotaxime or ceftriaxone. Ceftriaxone introduced after a month. The dosing is similar to adults, 15 to 20 milligram IV Q 8 to 12 hours. Ceftriaxone 2 gram every 12 hours. In children, 100 milligram per kilogram per day. When the patient is 2 to 50 years, the suspected pathogens, strep pneumo and Neisseria, antibiotic therapy needs to be given VANC plus cefotaxime ceftriaxone. The vancomycin is added for resistant when the ceftriaxone resistant is more than 1% in the population. The dose of cefotaxime is 2 gram IV every 4 to 6 hours, ceftriaxone 2 gram every 12 hours. In patients more than 50-year-old, Strep pneumo, Neisseria, and Listeria come into play. So antibiotic therapy varies. Add ampicillin along with vancomycin plus beta-lactams, ceftriaxone or cefotaxime. The dosing is very similar, 15 to 20 every 8 to 12 hours. Ampicillin 2 gram every 4 hours, ceftriaxone 2 gram every 12 hours, cefotaxime 2 gram every 4 to 6 hours. In, in patient with immunosuppression, again, the suspected pathogens are further expanded, including Listeria, Salmonella, and other gram-negative bacteria. Antibiotic therapy is vanc, cefotaxime or ceftriaxone plus ampicillin. Once the pathogen is identified, you need to narrow down the antibiotic therapy. When there is a Haemophilus influenza, even though it is less, they belong to two categories, whether it is beta-lactamase negative or beta-lactamase positive. The preferred agent for beta-lactamase negative is ampicillin. The alternatives are ceftriaxone, cefotaxime, cefepime, or fluoroquinolones such as levo, cipro, or moxi. Beta-lactamase positive patients preferred agents are ceftriaxone, cefotaxime. The alternatives are cefepime or fluoroquinolones like levo, cipro, or moxifloxacin. The common adverse effects when using antibiotics. Number one, you need to remember and also you need to teach the patient. Penicillin rash, GI adverse effects, ampicillin diarrhea, rash, hives, ceftriaxone or cefotaxime transaminitis, diarrhea, rash. Additional considerations such as it can cause seizures in patients with kidney failure. Cross-reactivity to other beta-lactams occurs in patients allergic to penicillin. Cephalosporins cross-reactive to other beta-lactams in patients allergic to penicillin, even though less, but needs to be observed and also to be taught to the other providers involved in the patient care. Neisseria meningitis, when the penicillin MIC is less than 0.1, the preferred agent is penicillin G or ampicillin. Alternatives are ceftriaxone or cefotaxime. When the MIC is 0.1 to 1, the preferred agents are ceftriaxone and cefotaxime. The alternatives fluoroquinolones such as levo, moxi, or cipro, or meropenem. Again, one needs to watch cefepime rash, diarrhea, nausea, may cause encephalopathy, cefepime. Ceftaroline can cause diarrhea, nausea, vomiting. This is the only cephalosporin has an effect against MRSA activity. One should remember that ceftaroline. Fluoroquinolone can have GI side effects, tendinitis. It can prolong QT interval. So check baseline EKG when you use fluoroquinolones. Strep pneumo, when the penicillin MIC is less than 0.06, preferred agents are penicillin G or ampicillin. Alternatives are ceftriaxone or cefotaxime. When the MIC is more than 0.12, ceftriaxone or cefotaxime. The alternatives are meropenem or cefepime. These are all guidelines came out of JAMA 2022. The side effects, vancomycin can cause nephrotoxicity, so the levels needs to be monitored. It can cause red man syndrome. Daptomycin can cause diarrhea, rash, and elevated creatine phosphokinase. So adjust the dose of vancomycin to reach the serum concentration 15 to 20. If there is no pneumonia, discontinue daptomycin, especially when the creatine kinase is more than 1,000 units or if there are myositis symptoms. Strep pneumo, when the MIC concentration is less than 1, the preferred agents are ceftriaxone or cefotaxime. The alternative is meropenem or cefepime, even there is a strep pneumo. When the MIC is more than 1, vancomycin plus ceftriaxone or cefotaxime. Alternatives are vancomycin plus fluoroquinolones, moxi or levo. Linezolid can cause diarrhea, nausea, and headache. If the linezolid used more than 2 weeks, up to one third of the patient can develop a reversible myelosuppression. So one should monitor CBC in those patients. Bacterium can cause GA symptoms, rash, and acute kidney injury. And when you use VANC plus ceftriaxone or cefotaxime, they have excellent cerebrospinal fluid penetration. The dosing needs to be very appropriate when you treat any kind of meningitis. When the isolate is an enterobacteria, the preferred agents are ceftriaxone or cefotaxime. The alternatives are aztreonum, fluoroquinolones like Cipro, Levo, and Moxi, Bactrim, Meropenem, or ampicillin. When the isolate is Listeria, the preferred agents are ampicillin or penicillin G plus gentamicin. Alternatives are Bactrim. Streptococcus A galactiae, which is GBS, the preferred agents, ampicillin or penicillin G. Alternatives, ceftriaxone, cefotaxime, or vancomycin. Staph aureus. It's often seen in immunocompromised hosts. Again, Staph aureus can be methicillin sensitive or methicillin resistant. If it MSSI, the preferred agent is nafcillin or oxacillin. Alternatives are vancomycin, linezolid, or daptomycin. Methicillin resistant, the preferred agent is vancomycin. The alternatives are Bactrim, linezolid, daptomycin, or ceftaroline. So how long one need to give the antibiotic? Again, based on the pathogen. If it is meningococcal meningitis, 5 to 7 days. Pneumococcal meningitis, 10 to 14 days. H. meningitis, 7 to 10 days. GBS meningitis, the duration needed is 2 weeks. In gram-negative meningitis, in neonate and younger infant, at least 3 weeks need to be given or 2 weeks beyond the first sterile repeat cerebrospinal fluid culture. Usage of dexamethasone in acute bacterial meningitis. It's recommended with bacterial meningitis beyond neonatal age in high-income countries. Dexamethasone does reduces hearing loss and neurologic sequelae in children and neurologic sequelae in adults. There are no beneficial effects of dexamethasone identified in studies done in low-income countries. Dexamethasone should be started with the first dose of antibiotics and continued for 4 days. In patients in whom antibiotic treatment has already been started, dexamethasone still be started up to 4 hours after starting the antibiotics. There are no dexamethasone should be given in Listeria meningitis, no dexamethasone in neonates. The dose is 0.15 milligram per kilogram every 6 hours. Complications and outcome of acute bacterial meningitis. The immediate complications are most of the patients do have cerebral edema and raised intracranial pressure. The routine monitoring of ICP is not indicated. The other common complications, hyponatremia is very common. So monitoring electrolyte and giving isonatremic fluids, very important. Sometimes hyponatremia is caused by, say, ADH. And very few times you can have cerebral salt wasting syndrome. So you have to remember to monitor electrolytes and monitor urine sodium so that you can appropriately address the volume and electrolyte. The patient presents with sepsis, septic shock, and DIC needs to be dealt immediately. Those patients are sicker patients, have a poor outcome. Seizures needs to be treated right away and with maintenance anti-seizure medications. Hydrocephalus, oftentimes So consequence of bacterial meningitis needs to be monitored and appropriate intervention by the neurosurgeons needs to be done. Again, axial fluid collections such as subdural and subarachnoid empyemas or effusions needs to be looked into if the response is not as expected when you are treating with antimicrobials. Late complications of acute bacterial meningitis are hearing loss, hydrocephalus, seizures, and cerebrovascular complications. When it is associated with septic shock, it's associated with poor outcomes. So you need to be aggressively treat shock plus meningitis. When there is a decline in consciousness or condition fails to improve within 48 hours after starting appropriate therapy, CT scan is indicated to detect hydrocephalus, brain infarction, empyema, or brain abscess. Seizure should prompt the initiation of anti-seizure medication. One should also consider non-convulsive status epilepticus. The only way to rule out non-convulsive status epilepticus, meaning the altered sensorium in the absence of brain infarction, empyema, or abscess, get an EEG done. That is the best way to rule out seizures in altered mental status. Cerebrovascular complications are common in pneumococcal meningitis. Arterial stroke occurs in 30%. Cerebrovenous thrombosis occurs in 9%. Intracerebral hemorrhage in 9%. Anticoagulant treatment should generally be withheld in patients with bacterial meningitis because it is associated with high risk of intracerebral hemorrhage. Then another complications often seen in the aftermath of acute bacterial meningitis treatment is delayed cerebral thrombosis. It is a hyperinflammatory syndrome involving extensive cerebral infarction days to weeks after the initial good recovery. Dexamethasone therapy seems to predispose this delayed cerebral thrombosis. Treatment is prolonged immunosuppression. During this time, one should consult ID and hemato-oncologists. It's not uncommon in patients with bacterial meningitis, increased ICP. How do you treat osmotic diuretics? Which typically, I personally use hypertonic saline, 3% saline, ventriculostomy, decompressive craniectomy. The timely intervention of decompressive craniectomy can save these kind of patients. ICP monitoring should be considered when there is an impending herniation. This is a very important part. Therapy should not be withdrawn early during the admission because the patient is comatose, especially when they are with preserved brainstem reflexes, because quarter of the patients, that means 25% of the patients, they can fully recover. So all the patients need to be appropriately without the treatment being withheld, especially those with preserved brainstem reflexes. Mortality rate. Pneumococcal meningitis carries mortality rate of 10 to 37% in high-income countries and up to 54% in low-income countries. Meningococcal meningitis is associated with a mortality of 3 to 10%, listeria 35%. That means 1/3 of them will not make it. Neonatal meningitis, again, there is a geographical difference. 10% in high-income countries, 58%. That means half of them will die in low-income countries. Neurological sequelae from meningitis. Half of the survivors suffer from focal neurologic deficit, hearing loss, epilepsy, cognitive impairment. Even the neurologic sequelae has a geographical difference. In Europe, the neurological sequelae is 10% versus almost quarter of them, 21 to 25% in Southeast Asia and Africa. The high risk of long-term neurological, neuropsychological deficit impair the daily life activities and quality of life in adults. So it's very important in meningitis patient identification and treatment immediately, because high mortality, even those survivors, half of them will suffer from other neurodeficit. The pathogen-specific morbidities: Neisseria 7.2% morbidity, H. flu 9.5%, strep pneumo carries 24.7%. Since strep pneumo being the predominant organism, early identification, treating aggressively with appropriate dose of antibiotics, very imperative. What are the risk factors for morbidity? Older age, hypotension, seizures, no antibiotics prior to hospital admission, concomitant pneumonia, purpuric rash, tachycardia, lower GCS scores, focal neurologic deficit, CSF white cell count less than 1,000 cells, positive blood culture, and high serum CRP. Recurrent meningitis seen in 7% of the patients. The risk factors are cerebrospinal fluid leakage, asplenia, and hyposplenism. So when there is a persistent cerebrospinal fluid leakage or surgical repair of the leakage needs to be done, in addition, one need to vaccinate them against strep pneumo, Neisseria meningitis, and H. flu type B. In patients with asplenia or hyposplenism, they should be vaccinated against strep pneumo and H. flu type B. In all patients with pneumococcal meningitis, should be treated with PPV23 and PCV13 because of the risk of recurrence. The recurrence is about 7% in pneumococcal meningitis. This concludes the seminar on acute bacterial meningitis. If you like it, please share it with other medical providers. Thank you for watching.